Hello, Adad.
Hi, everybody. אז I'm going to say a few words in Hebrew. אוקיי? So, שלום לכולם, ברוכים הבאים. אנחנו שמחים לראות אתכם כאן איתנו היום בוובינר חשוב ומרתק זה. אין ספק שהתחום של טיפול בתפקודי הפה הוא אחד הנושאים החמים ביותר היום, והרופאים המבינים ושכבר עובדים עם זה בעולם, מבינים כמה זה קריטי לבריאות של המטופלים. המוצרים שלנו, MYOBRACE, מיוזה, מיוטליה, הם בדיוק מה שכולם מדברים עליהם עכשיו, ואנחנו כאן כדי לתת לכם את כל הידע הדרוש לשילובם בקליניקה שלכם. אנחנו רוצים להודות לכם שהצטרפתם היום, ובמיוחד על הרצון ללמוד, להתפתח ולשפר את איכות הטיפולים שאתם מעניקים. ולפני שנתחיל, חשוב לי לעדכן שבסוף הוובינר אנחנו מציעים הטבה מיוחדת של 1+1 לרכישה באתר שלנו, וזה תקף להיום בלבד. ועכשיו אני שמחה להעביר את רשות הדיבור לדוקטור בארי רפאל, שהוא מומחה מארצות הברית, הוא אורתודנט בתחום תפקודי הפה והנשימה. הוא ילווה אותנו בהרצאה חשובה עם המון ידע. ודוקטור רפאל, the stage is yours.
Right, thank you. Shalom, everyone.
שלום.
So good to be here. I'm hopefully I had met many of you when I was there in November, and thanks to Hadass, who's here today, and Ayal, who's I think gallivanting out in New Zealand now. They brought me in for me to make a contribution to Israel and Israel's society that I was just so honored to do, and I can't wait to come again next November, and then to spend some time with you doing these webinars. We have 3 webinars planned, and each one will be a little bit different. So I hope you find some value in it. It will play on what I talked about in November, but I will go through some of this again for those of you that may not have been at that wonderful conference. I think one of the nicest things that happened at that conference is that it brought together people, many of whom already had the ideas that I was talking about, but didn't realize that so many others in the country were also concentrating on it. So it seems as if there is some momentum that's built up where we realize that we have to work together for children's health. And so that's what I'm going to be talking about today. I'll do a little bit of disclosure in that I have a private practice. It's just west of New York City. I've been in practice since 1983. That's a long time. I do have a group that teaches this material called the Airway Collaborative. Someday, some of you may want to come over and participate in that. It's a broad education in airway dentistry and medicine. I do teach these principles at some of the schools here in the U.S., including a couple orthodontic residencies, which I'm very proud to do as a specialist in orthodontics. I do get paid by the Myofunctional Research Company, not for today's lecture, but on occasion. But otherwise, I have no financial connection to the organization. I use their products. I pay the same fee for their products that you do. And other than my honorarium, I don't have a financial interest. So let's start off by looking at what is a typical case in my practice. This is Sebastian. He's 5 years old. Mom's a physician, and she wanted something for Sebastian that was a little different than what she was being told at her dentist and her orthodontist. Many of you in pediatric dentists would look at this case and suggest that in order to make room for the lateral incisors, you might have to remove those primary canines. It's a typical technique that's used when the teeth are so crowded. And it's the beginning of what we often call a serial extraction technique. From a tooth point of view, he also has worn down his teeth because he's grinding them. That's something that many pediatric dentists write off as so-called normal. He does have an anterior open bite. This whole idea of malocclusion, that is, teeth that are not coming in properly, has been thought in many ways to be just something that you have. It's a personal characteristic, maybe inherited from your parents or a combination of things from your parents. But there's more to it than that. In fact, I don't really see the problem as teeth so much anymore. The one thing that we see in his mouth is that his jaws are just not developing as fully as they should. The palate being collapsed, the lower jaw being receded. So his mom brought him to me because she was noticing some other symptoms, that he was breathing through his mouth at night, he was snoring. It seemed like he would stop breathing a little bit. She knew his tonsils were large, that he'd get sick quite a bit. He was not thriving as much as she would like to see. And then, of course, she noticed these crooked teeth. So she said this, I'm a medical doctor. I'm looking for solutions and she has a strong interest in holistic and integrative medicine. So, as she says, the classic method of pulling permanent teeth was not an option for us. So here he is at 6, and we've got him started with the MYOBRACE technique. Now, as you'll see, MYOBRACE is a mouthpiece that kids will wear. We ask for an hour of wear a day and to bed at night. So it's not that difficult a technique as far as that goes. It has some limitations. It doesn't solve every problem any more than owning a set of dumbbells makes you strong. The MYOBRACE is really an exercise accessory. And so there are activities that go along with them. These activities have the same goals as what you might know of as myofunctional therapy. That is, we teach kids to breathe through their nose, keep their lips together, their tongue resting on the roof of the mouth, and then being able to swallow competently with the tongue and not have to use the facial muscles. It's basically those 4 kinds of habits that will either help the face grow properly or get in the way of good facial growth. One adjunct to using the MYOBRACE is that wire that's on the palate. It's a removable lingual arch. It's adjustable. Developed by Chris Farrell, the developer of MYOBRACE. He calls it the bent wire system. Orthodontists will know it as a removable lingual arch. And you can see already as the treatment is getting going that we're starting to open up spaces for those blocked out lateral incisors. In fact, You can see them starting to come in under the wire and behind the wire, erupting on the palate, which is pretty typical for jaws that haven't developed that well. Teeth don't really have genes that tell them where to come in. They basically erupt into the space that they have, following a path of least resistance. And if there's not enough room for them where they're supposed to be, then they'll come in somewhere else. But she also Mom talked about that swollen lymph. So I'd like to address this. I know that a lot of dentists and even physicians who are that are familiar with this airway problem do consider how the tonsils and adenoids block the airway. So all physicians and dentists, they want to shrink the tissue so that it doesn't block the airway. Shrinking the tissues is usually done by medication of some sort, either antihistamines or steroids, and if it works, then the surgery might be avoided. But I'm going to suggest there's another way of dealing with it, because once the tissue starts getting swollen and a child starts breathing through their mouth, they enter this vicious cycle where the air that they breathe is not being filtered by the nose, and so swells all the more. And unless you address not only the size of the tonsils, but the way we're breathing and the behaviors that surround breathing, then you're not going to really be able to make much of a difference. So breathing modification often entails helping the jaws grow so that the anatomical airway is open, reduce swelling and inflammation, which is often looking at the root cause of the initial swelling at the beginning, but then also try to reestablish nasal breathing so that the air that reaches the tonsils and adenoids has already been filtered and warmed and moistened and literally sterilized with nitric oxide from nasal breathing. So if these things work, great. If not, then taking the tonsils and adenoids out still may be a necessary solution. But we know that removing tonsils and adenoids has a 40% chance of recurrence. And the reason is that, at least here in the States, the ENTs do not take the time to teach a child how to clean their nose, clear their nose, use their nose, close their mouth, use the diaphragm, regulate oxygen and carbon dioxide in their breathing. And so if a child has their throat cleared by taking out the tonsils and adenoids, but still breathes through the mouth, there's a high chance that it's going to happen. So we always do the breathing modification after surgery now. And of course, the question is, if you're going to do it after surgery, why don't you do it ahead of time? So it's not, tonsils and adenoids are not the only problem we see with the airway, but it's a great example of how this new way of thinking can be beneficial. So here's Sebastian at 7 years old. He's had his tonsils removed. You can see on that upper left picture, he has his lips together. He's breathing through his nose better. I'm still working with the bent wire system, trying to nudge those lateral incisors forward. I'm doing nothing else on the lower arch, but have him wear his MYOBRACE. The lower arch is starting to recuperate, really just as a result of changing muscle function, but also helping the upper jaw develop. And here he is at 8 years old. It does take a long time to do this, because really we're just reorienting growth. We're not forcing growth like we do when we use things like palate expanders. And a palate expander would have been a useful approach for Sebastian. But I tend to favor those approaches, natural growth, because that tends to be more stable. And so you can see the space for the lateral incisors has increased. They are nearly aligned now. The open bite in the front is closing simply because he's keeping his tongue in his mouth. He doesn't have to push his tongue out of his mouth anymore just to keep it out of the back of his throat. So you start to see these changes in the teeth that are signs that the function is improving and breathing is improving. The good arch development that we have on the lower arch, that's really just a product of changing muscle function. And this is an important point, because when muscle function is correct, the face grows well, the teeth come in straight. When muscle function is incorrect, the teeth cannot develop well. And I did do braces for him to finish off, but it was less than a year's worth of detailing. And this is how I like to do it. I'm going to say that maybe 30% of my cases don't really need braces. 30%, it's discretionary depending on how perfect the parents want the teeth or the child wants the teeth. Granted, 30%, they're still going to need significant orthodontic treatment, depending on when they come in, how early I get to see them, how well they cooperate with the program. It's not always so easy to get a kid to do this work. But now he's much healthier, and his mom reports that not only his teeth look nice, but he's getting restful sleep. He's breathing through his nose. He barely gets sick. She says he's thriving in every way. And of course, I'm happy about that, because I not only gave him a nice smile, but I gave him a leg up in his growth and development in total. But it begs this question: why did this happen to him? And why is it happening to so many children? And so I want to address this as part of the context of why we use MYOBRACE and why we have to pay attention to how children are growing and developing early on in their lives. So there's this concept of evolutionary medicine, which suggests that through the hundreds of thousands of years of human development, and if you're not happy with the evolutionary theory, then even what Hashem gave us to begin with, that our genes really are for a healthy, surviving body, a vital physiology, a competence for handling life and survival and reproduction and so forth. But in the last few hundred years, our genes have not been able to express themselves quite the way that they used to. And especially in the last, say, 400 years, 500 years since we started refining sugar, since we started mass producing food, since we started putting elements in our food that really are not meant to be food at all, many petroleum derivatives like antibiotics and pesticides and colorings and flavorings, some of which are designed to get us to eat more than we really need to. Our physiology has started to change. So this idea of a mismatch between our genes and the current environment has had us express a whole host of chronic non-communicable diseases of civilization. And they are becoming more common, more intense, and unfortunately, they're beginning to show up at younger and younger ages. And what we also know, and something that I consider to be part and parcel of this chronic disease of civilization, are the things that we as dentists deal with every day. Caries, malocclusion, and now sleep apnea are really just chronic diseases. And unfortunately, in some ways, dentistry has become separated from medicine. And so we think that the ailments that we treat every day are not medical conditions, but they are. Did someone draw on my screen? Thanks for the emphasis there. But this leads to a hypothesis that we base our education on, and that is our bodies have developed competencies that help us thrive and survive. One of them, of course, is breathing through the nose. But there are many stressors in our modern environment, from the things we eat, the things we put in our skin, the things we breathe, the way we use our bodies, the way we medicate ourselves, the way we use our bodies in our modern sequence of activities. For instance, we tend to sit more and stare at screens and hold our phones up more in this modern environment than we ever did. It's almost strange to look out at the horizon. So someone needs to turn their microphone off. And when we encounter these stressors, our body really can deal with it, as long as it doesn't overwhelm us. But after a while, we actually have to choose behaviors to mitigate the stressors, and we call those compensations. So if you can't breathe through your nose because the way our bodies are reacting to the modern environment closes the nose off, then you have to find another way to breathe. That other way to breathe, of course, is going to be to open the mouth. And it solves the problem. We still get air. We can still survive the next day. But every compensation has unintended consequences. And these unintended consequences are the compromises or the chronic diseases of modern life. And once you get into that cycle, it goes around and around and around. Other competencies get challenged. It's more of a stress, more compensations, more compromises, so forth. So many anthropologists and physicians have been looking at this idea of chronic disease being a product of the expression of our genes, and that there has certainly been a change in the way our bodies are developing. Most importantly for us is that our jaws and our faces just do not fill out the way that they used to. And it's an important concept. As an example, here are two boys in my practice, one of which came in, his mother was also a physician. She was a naturopath and fed him well. And he breastfed early on in his life. She makes sure he eats natural foods. She was a little concerned because the way his front teeth were coming in just didn't look right to her. But I assured her that this is the way kids grow up. This is the way kids look when they're going to grow up with straight teeth. And so he didn't really need my services at all. But the next day, another boy comes in, and he is typical of all the chronic diseases that we see in kids that are growing up with crooked teeth. And that is, he's unable to keep his lips together. He cannot breathe through his nose for more than a few seconds without feeling like he's running out of breath because he's so unused to breathing through his nose. He can't sleep well at night. He pees in bed at night, even though he's still 6 years old. He grinds his teeth, which is really a sign or a symptom of arousals or trying to open the airway. And he's just not doing well. And you can see the same kinds of symptoms in his mouth. Those teeth are certainly crooked. It's a malocclusion, but it's not the teeth's fault. It's a fault of the fact that the jaw bones, the container that holds the teeth, is not developing well. So here are those same two boys. And you can see by their skeletal structure that one has a maxilla, especially the maxilla, that has grown broad and wide and strong and robust. You can see his nasal cavity is open better, and the teeth are coming in straight. On the other hand, when the mouth is open, the maxilla collapses in 3 dimensions of space. It not only gets narrower, which is what a lot of dentists will be aware of, but it's also falling downward, and it's not growing forward the way it should. That bone cannot accommodate all the teeth, and they have to literally play this game called musical chairs. I don't know if you play that game in Israel. Something, the kids play. Their music is playing. There's 12 kids. They're fighting for 11 chairs. Whoever can't find a chair is out of the game. And that's what happens with teeth. Whoever can't find room. Orthodontists are just very quick to take teeth out. But it's not the teeth's fault. If you look at the palate of both these boys, you see the difference. The palate's supposed to grow broad and wide, but when it collapses in 3 dimensions of space. And I try to teach my students to see this as a deformity, not just a personal characteristic, not just what somebody has, but as a process of collapse that's happening when the patient walks in. And if you don't do anything about it, they're going to continue to collapse until they wind up with such crooked teeth that an orthodontist will want to take out permanent teeth, maybe not even have a choice. So this is not a new idea. You may have heard of John Mew up in England. His son Mike is now carrying the banner, frankly being persecuted for these thoughts up in England. But the idea is very simple. This is the way a face should look. This is the way a face should look if it's growing properly. But if the face changes shape, the teeth are not going to have room to come in. And it's gotten so bad that the lower part of the face actually swings down and back in the face. This shift has happened universally across the world. It does not matter what your genetic or social background is. This has been shown to be happening all around the world. And so this part of chronic disease has become endemic. And if you compare them like this, you can see that this change in thinking is different than what I was taught in my orthodontic residency. I was taught that the relationship between the upper and lower teeth, which we judge by what we call the angle classification, is an expression of the inherent characteristics of the person, and that a class 1 occlusion is very different than a class 2 or a class 3 occlusion. And frankly, we use angle classification as a diagnostic and treatment planning criteria, and yet the angle classification does not explain this downswing in the face, because you can have the downswing and have all 3 of the classifications. That is the relationship between the upper and lower teeth. So this is a change in paradigm that I think is really important to understand. Once you see things in this way, you'll understand that the change, the real treatment, has to be directed at the problem, the root cause problem, which is not the teeth. And one is that the maxilla is not filling out, and you see that as insufficient mid-face growth, because the maxilla includes not only the teeth, but goes all the way up to the borders of the orbits, surrounds the nose, attaches to the cheekbones, etc. When the maxilla does not grow well, it falls downward and back, as I say, in 3 dimensions of space. The nose will often collapse as well. And so when you see that hump on the nose, that may not really be an extra bit of growth. It may be a downswing of the nasal cartilage from the nasal bone. And finally, the poor mandible is a victim to what's going on in the maxilla, and sometimes it can keep up with the maxilla, and you have a class 1. Sometimes it is hampered by this growth, and you have class 2, or it may escape the whole drama, come forward and create that class 3. So all 3 of the angle classifications can happen within this paradigm. And I see this craniofacial deficiency all the time. Mike Mute calls it craniofacial dystrophy. We're using a word that perhaps is a little less harsh, just so that patients understand that this is not so much a pathology as it is a developmental disturbance. And I see this all the time. I'm not going to talk much about this case, but I put this slide up because here we have a 14-year-old that came in to see me who's suffering all of the maladies that are associated with bad breathing. We look at the 3-dimensional x-rays, the cone beams, so that I can look at the internal aspects of her breathing space. Look, she's got a deviated septum and swollen turbinates. And you can see by her picture, she has to have her mouth hanging open in order to breathe. The quality of life scores are very important. These are issues that I think we need to deal with. We'll go over that in another lecture. But these are important issues that are totally separate from the teeth. We look at the graph with the blue lines. This is a sleep inventory. It's a validated instrument that shows me just how much trouble a child is having breathing, or if their sleep is restless, or how their sleep habits are, or whether it's affecting their daytime behavior. And of course, for this girl, it certainly is. We look at her posture on the bottom left. Noticing how she has to hold her head so far forward of her shoulders just to keep her airway open, that it's putting extreme stress on her cervical and upper quarter muscles. Of course, it's not strange to see that the teeth are crooked, that on the upper right, those little red hash marks, the little red lines are supposed to match. And unfortunately, the way I was trained in orthodontics was to push the top teeth back to meet the short lower jaw. But now we know that if you don't bring that lower jaw forward, you're only going to lock in the breathing problems that she already has. So I was trained as an orthodontist. I practiced orthodontics for 30 years. I loved it. I still love it. I mean, pushing teeth around is really very gratifying because it's so concrete. You can see the benefits of your work. But in 2008, so this is already a decade and a half ago, I read this article about MYOBRACE from Herman Ramirez. He's a dual degree pediatric dentist and orthodontist, and he was talking about the trainer system, and he said something that struck me at the time. Maybe I was ready to hear it, but it was one of a number of things that happened to me that pried my mind open to question some of the things that I was taught in my orthodontic residency. And he said this: soft tissue dysfunction is the cause of malocclusion. And I capitalized the THE there because now that I understand this, I understand that 80% of the malocclusion that we see is preceded by bad breathing, bad posture, the way we chew, the way we eat, the way we swallow, the action of the muscles in the mouth. It is not part of our genetic inheritance that we have crooked teeth. But so it is. And it had me look at this thing called MYOBRACE again. I had seen MYOBRACE at a professional conference some years ago. I bought 6 of them and I handed them to the kids. I said, here, try this. And of course, handing a child something and say, try this, it's like handing them a jump rope and say, here, try this. It doesn't really do anything. The MYOBRACE is not really a brace, you know, an active appliance like the name might lead you to believe. It is in fact an exercise accessory, much like dumbbells or weights or jump ropes, but they have to be taught. People have to be shown what to do, not just to wear the MYOBRACE, but to learn the habits that we teach with the MYOBRACE. And so it's more than just an oral appliance, and it's important to understand that. But there are versions for kids and you know, of people of every age, and each series has several different different appliances. Much like when you go to the gym and lift dumbbells, you might start with the 5-pound one, but pretty soon you're going to need something heavier. And eventually, when you're strong enough, you challenge your body with even more sophisticated methods of training your muscles. And that's what we're doing with MYOBRACE. We are training muscles. So it's just a mouthpiece that you put in your mouth, you close down, you close your lips, and you put your tongue on the roof of the mouth. This is what I say to the kids. While you're wearing your MYOBRACE, have your lips together and your tongue on the roof of your mouth, as high up as you can. And if they do that, they are actually exercising and retraining their muscles. So like myofunctional therapy, there are 4 basic goals of treatment. One is to breathe through your nose most of the time. Yes, there are times when breathing through the mouth is indicated. If you're doing something that produces a lot of carbon dioxide and you need to get rid of it, then you can breathe through your mouth. But otherwise, once you get used to breathing through your mouth, it becomes even harder to breathe through the nose. And so establishing nasal breathing as the major competence is important. Secondly, establishing good tongue resting position, which is not on a park bench, but up on the roof of your mouth. The tongue acts as a scaffold for the upper jaw bone to grow. And it doesn't even have to push that hard. But if it's resting there, the maxilla will take a very different shape, even if it's for just 6 to 8 hours a day. We also teach correct swallowing, which is using the tongue up on the palate to create a seal for food, and not necessarily, and not in between the teeth, not between the side, the posterior teeth, not between the anterior teeth, and not having to use your lips or chin or cheeks to help you swallow. When you have a competent swallow with your tongue, you don't need those accessory muscles. And it's the overuse of the lips and the chin and the cheeks and the neck muscles that help teeth come in crooked. And then finally, teaching teaching people to keep their lips together at rest is important. Not puff their cheeks like this. But this is just representing an exercise that we teach the kids. But if you can keep your lips together at rest, then you can keep your tongue on your palate. If your mouth is hanging open, 9 times out of 10, your tongue is not resting in the right spot. And then we put this all together with body posture as well, because the way you carry your body, the way you stand, the way you sit, the way you use your body is all very important. So the MYOBRACE is kind of a simple device, but it's got certain features to it which make it helpful for teaching these 4 habits. It has the lip shield in the front, which of course, once you put it in your mouth, you no longer can easily breathe through your mouth. You have to start breathing through your nose. That may take some time. It may also take teaching a child how to blow their nose, how to rinse their nose, how to clear it, how to reduce inflammation, how to reduce swelling. It has these little nibs and a flange that goes down under the upper lip, and that is to remove the influence of the hyperactive lower lip and mentalis muscles, and it even discourages the chin muscle, the mentalis muscle, from being overactive, at least eventually. It has a little target built into it so that the tip of the tongue can be directed up toward the roof of the mouth. It has channels both on top and bottom that help guide the teeth into place. And this is why you see those beautiful arch forms developing. And finally, it keeps the tongue within the oral cavity and not pushing on the teeth, not getting in between the teeth. So all these things are used to retrain the muscles. We ask the kids to wear this 1 hour a day while they do certain exercises, also derived from myofunctional therapy, but they have to be done consciously. So they don't have to wear it to school. They don't have to wear it out of the house. But they do have to sequester 1 full hour a day. And then, of course, they can wear it to bed at night because that helps them breathe through the nose while they're sleeping. And when they swallow, they automatically practice what they've learned during the day. So here's a case that was also successfully treated with MYOBRACE. I like to use this case to brag because it really was such a dramatic shift, but I will be the first to tell you that not all cases will work out this well. Every child has their own obstacles. Every child has their own challenges. And sometimes the challenges are so great that it makes it very difficult for them to just wear the piece. and we have to meet each child on their own terms. But in this case, and he was already 9 years old. He's in the mixed dentition. He's got he's starting to change over his posterior teeth. He has a narrow collapsed palate, craniofacial deficiency. His chin is set back quite a bit. He's got moderate crowding. He's got a collapsed palate. He's got crossbite in his teeth. And there are a lot of things that we look at, not just the teeth. We look at things like how the frena under his lip, under the tongue tie are so tight. I'm so proud of Ayal and Hadass there in Tel Aviv that have every child that's being born at the Chalav Center being evaluated for tongue tie. But we look at the way they stand, how their feet are planted on the ground. We look at their nostrils and look for swelling in the turbinates and good hygiene. This boy didn't have much dental problems. He really could have been developing quite well. Skeletal structures were good, but he also had hypertrophy of the tonsils. And the question always is, if you're going to treat a case like this, where the airway is being blocked by the tonsils, looking down on it, that slit is what he's breathing through. And this is while he's awake and sitting up, because that's when I take the x-ray. What happens to that space when he lies down at night? He doesn't have his tongue resting on the roof of the mouth. And so all three things are blocking up that pharyngeal airway. He has a little bit of a deviated septum, but the turbinates are a little more swollen on one side. That actually can be a natural cycle, which is fine. But we look for those passageways in the nose that may be blocked or swollen, and his jaw is narrow. The caliber of his throat in that narrow spot is just 30 square millimeters. That's like 5.5 by 5.5 millimeters. That's maybe like a bubble tea straw. We should have something that looks more like a garden hose to breathe through than a straw. But this is important. So, again, when I was taught orthodontics, this is angle class 2, and we used to be taught to put on a headgear to push the upper molars back, pull the upper front teeth back in order to get good overbite. But the question, of course, is, do you want to retract those upper incisors when you have such a threatened airway? And, unfortunately, I was, and many of my colleagues still are, hesitant to acknowledge that the way the face is growing has anything to do with the airway, or the jaw joints for that matter. And it's time for us to get past that old defensiveness and take responsibility for how a child is breathing, how their anatomy looks, how their physiology works, and so forth, and the habits that are making this happen. So you can see the retrognathia of the lower jaw. Here I had him just posture his jaw forward in a way that doesn't really solve the problem for him, but it does give me a good indication that I don't want to lock that lower jaw behind. He was showing a little bit of signs in the temporomandibular joints and the jaw joints, but that will happen, and it will express itself even more if that lower jaw can't grow forward the way it should because of a deep overbite. That those joint spaces are going to show wear and tear over the years. So here's where he started in 2017. Here's where he started in 2017, and here he is just 5 months later, this is a remarkable change in that I don't really see this kind of change this fast, but it's one of those object lessons to see that to show how things can develop when you change the muscular posture. So, some of these baby teeth are falling out, new teeth are coming in, but the collapse of the maxilla is starting to open up. Yes, his mandible is still retrognathic. It's just not going to grow that fast, but he's now in a much better place than he otherwise would have been. We had to evaluate for the tongue tie because many times that tethered tongue can't rest on the roof of the mouth and is very much an underlying problem for a lot of kids. I try to give the tongue as much of an opportunity to learn how to be on the roof of the mouth, and we make decisions about frenectomies a little bit later on. But I'm going to be watching him for palatal remodeling because once the tongue gets up there, the body will change. It takes a long time. That's fine. We have a long time to live. It doesn't all have to be done in 2 months or 3 months or 1 year. And here he is a little bit later on. All the permanent teeth are in up to the first molars. And I'm really happy. Midlines are on, crossbite's gone and all that. Face is looking much better. He's a bright kid. He's doing well in school, sleeping well. And then what happens? Here, I bring him in for final pictures and look at his second molars. Second molars started coming in lingually and kind of ruined things for me. I had to go back and treat those molars and get them back in alignment. So I have yet to get his final models, but that's something that we're looking at. But that's a big, beautiful arch form. That's the way humans used to be before the modern era. And we know that because the anthropologists are showing us skulls with 32 straight teeth. That includes wisdom teeth. That is how humans grew up to just a few hundred years ago. So the MYOBRACE system has become very helpful for me. On our next visit, next webinar, I'm going to talk a little bit more about how I use it, how I set it up in my office. I'll be able to give you dentists some tips on how to do that, how to train your staff and what physical facility you need and so forth, and how to organize around that. But those of you that are not dentists, and maybe, I think, a physician could, in fact, use this if they're doing health education as well. So just to finish off, this idea of chronic illness has become a big topic here in the United States. It probably is, worldwide a major problem. The World Health Organization declared some 5 years ago that chronic disease was the leading cause of death worldwide. And fortunately, it's kind of become a bit of a hot topic for us because with our new administration, we have now someone who's going to make a campaign for making America healthy again. This MAHA is a play on the Make America Great Again piece. I'm not sure how I feel about all of it, but I am very much in favor of this Make America Healthy Again piece, because there are things that really need to be done, and we can do them. Chronic disease is all a product of things we do. That's either culturally or individually. Culturally, we have things that we can do to create better farming so that the quality of the food that we use is not just plentiful, but healthy. We can protect our natural habitats. We can especially expose the influence of the corporations on government functioning and government agencies that are being corrupted by the companies that they're supposed to be regulating. It's just something that happened slowly, gradually. I don't think people intended to do this, but we found ourselves following market influences more closely than we followed our own health. And it's time to change that. So fortunately, we may be able to do that. Now, a few years ago, the American Dental Association also took a stand a little bit on this idea that the dentists have a role in medical treatment with some caveats, and that is sleep apnea is a medical problem. It is not a dental problem. And they were quick to warn dentists not to diagnose sleep apnea, not to treat sleep apnea, except as an adjunct to medical treatment, because we are experienced and capable of making oral appliances that can be used to help open up the throat or help expand the airway. And that's a great thing. But there was also a segment here talking about how to treat children. And I'm going to read this out loud because this has become, for me, a major motivation in what we do. And that is, in children, screening through history and clinical examination may identify signs and symptoms of deficient growth and development. So in a way, that's what I was talking about this morning. We've got to look at the face, not just the teeth, but at the way the whole face is growing, and other risk factors that may lead to airway issues. That is, how well a child is breathing through the upper airway from the tip of the nose to the bottom of the throat. If the risk for sleep-related breathing disorders is determined, intervention through medical and dental referral or evidence-based treatment may be appropriate to help treat sleep-related breathing disorders. And here is my favorite part, and or help children develop an optimal physiologic airway and breathing pattern. I used to be very happy to help children develop a beautiful smile so that they could have a nice picture at the bar mitzvah or the prom or their graduation from college. But to me, that is all secondary now. Straight teeth and a beautiful smile, they are the icing on the cake, if you will. But helping a child develop an optimal physiologic and airway breathing pattern is, to me, the most important thing that I, as an integrative orthodontist, can do. And what we'll talk about next time is how we look at this through the ages, from adults with sleep apnea and newborns with challenges in breathing right from the get-go. So, תודה רבה. My email and website are here, and we'll meet again on Sunday, April 16th at the same time. I'm going to talk a little bit more about airway orthodontics and our goal, and then I'll talk about how I organize MYOBRACE in my practice. Silmet-hafatza achshav. Let's hope that everybody comes home safe and sound before too long. Amen.
Amen. Barry, let's ask if someone has a question. So because I
Sure.
saw, so you can ask now.
And my Hadass, please come on and say hello. I want everybody to know
Hadass, she told me she's driving. I don't know if she finished driving. But she told me she's driving.
But Hadass was one of many pediatric dentists in the in Israel that are getting involved in this, and she'll be a terrific resource for those of you that want to help provide these services for your children. And then other of you, your dentists, connect with Hadass, because we'll make arrangements for teaching a lot of this material, not only with MYOBRACE, but with other techniques. So sure, ask questions.
Someone wants to ask a question? Because I saw earlier, someone wrote on the chat a question. I can't see it now. Okay. So anyone? Okay, so thank you very much, Dr. Barry. Thank you everyone for coming.
You're welcome.
You have 1+1 today on our website. So if you want, you can contact me or can go on the website and buy. And thank you very much, everyone. It was a pleasure. Thank you, Barry.
Shalom Aleichem.
Bye, להתראות. Bye bye.
תודה.
בבקשה, ביי. מיטל רו, תודה רבה. תודה גם לך, מיטל, שהיית איתנו.
I'll hang out with you for a little bit, Shlamit.
Yes, we'll stay till everyone comes out and then we can speak.
Nobody wanted to ask any questions.
They understood everything. It's good.
All right, good. So I know that Das and Ayal were arranging to have the Shalva Center in Yerushalayim.
Oh, what is this, Shalva?
Shalva. If you've never seen it before, it's an amazing place.
Ah, it's the place for the deaf kids?
Yeah, deaf kids.
That they are singing.
Special needs, all kinds of things. 6 floors of education and therapy. And they have a large auditorium, larger than we had at Ichalav. And hopefully we'll get it filled up, you know. So, but that's November 6th and 7th. And I wrote to Moshe about this. On the 6th, we'll do lectures.
Okay.
On the 7th, which is Friday morning, you know, we'll finish at noon so everybody can go home and get ready for Shabbat.
Okay.
But we'll probably do some workshops. And we can certainly do a MYOBRACE workshop that day for those that want to learn a little bit more, get some hands-on.
On the 7th, you mean?
Yeah, on the 7th. Yeah.
Okay.
But also, since I'm coming over, I want to do a separate educational seminar. Could be on Sunday. It could be on Monday. I don't know how you want to work it. I am at your service.
Where do you going to stay, in Jerusalem or in Tel Aviv?
I don't know. I could do both.
Okay.
Wherever
So
you need me, that's where I'll be.
Okay, so I'll ask Moshe, what can we do? On the 6th, there are lectures. On the 7th, it's Friday.
Yeah.
And we can do a more workshop.
Yeah.
Okay, so I'll talk to him and we...
Tal wants to ask a question.
Tal?
Hello.
Hi.
Hello.
I just wanted to ask about the, wait, I have a computer here. I just want to ask about, you know, the wire method.
Yes.
How is it different from, I don't know the name of the appliance in English, I think quadruple, something, like it's like a wire that has like two,
Yeah. Yes, it's called a quad helix.
Yeah, quad helix.
Right. Quad helix is a commonly used slow expander. It will help the arch develop laterally. So it, you know, helps make the arch wider. But it doesn't really help in the sagittal direction. It doesn't help the teeth come forward or jaw come forward. And the sagittal correction is just as important as the transverse correction. Are you in what's your field?
I'm doing an internship in pedodontistry.
Oh, good. Yeah. So there are a number of approaches, some faster, some slower, that are helped to develop that maxilla in 3 dimensions of space. To help it get wider, yes, and you know, perhaps palate expanders. They're the thing that most people will start with because most dentists and certainly most orthodontists are used to doing that. But the idea that the palate has collapsed in 3 dimensions of space, I think, has gotten lost on us. We have to help develop.
I wanted to ask about it too. I mean, we know that breathing through the mouth usually makes the tongue stay low, and then the arch of the palate is supposed to be high, no?
Right.
Not collapsed. So how does it fit with a collapsed palate?
Yeah. So, well, that's exactly what I'm saying. You have to make the repair in 3 dimensions if you can. And transverse, the side to side, that's the easiest. Getting the maxilla to travel forward in the face is the next most difficult, but just as important. And then preventing it from sinking vertically is critical, and it's the one thing that orthodontists have struggled with. You know, that long face and open bites and so forth have been very, very difficult. We just can't do it well with braces, and it's rarely stable. And especially if you wait until braces age, it's almost too late to change the face. But if you can change the habits early on, even if the bone has dropped a little bit, if you stop that vertical collapse and help the child grow, they can grow into it in a much better way. It's not something we can do for everybody, but until you see the problem as a 3-dimensional problem, you're never really going to fix it.
I'm sorry, just for a second.
Sure.
I have a lot of dogs. And I wanted to ask about the MYOBRACE.
Yes.
What happens if, you know, a tooth that, if there is a crowding and the tooth is not, I mean, it's really ectopic.
Yes.
So
well,
the appliance for each patient, or is it like a general appliance?
The MYOBRACE itself is a prefabricated appliance. They come in different sizes, and there are the different versions of it for each age. And it is not going to correct every, bad eruption problem, but it is essential to change the habits that are making that happen, making that collapse happen, if you want good long-term stability. So it becomes an important adjunct, even if you have to use other techniques. Now, I'll do rapid palatal expanders if I have to. I'll do removable expanders. I'll use the ALF, which is a light wire expander. I'll use whatever technique I think is appropriate for the child, but always they have to be taught good habits. Now, MYOBRACE happens to be the easiest way for me to do that because I can apply that in a dental practice, in an orthodontic practice, well. Some kids will do well with myofunctional therapy, where they have one-on-one attention with a specially trained speech therapist or dental hygienist. Right.
Yes.
Yeah. So lots of different approaches. When I come in November, I'll talk about that full range of approach. But the MYOBRACE, I'm going to say, I don't know, 80% of my patients will have that at some point during their treatment. Could be early on, could be the way we start, it could be after I fix the anatomic deficiencies.
Okay, thank you so much.
You're welcome. Good luck in your residency.
Thank you. Have a nice
day. You're opening your mind to this.
Anat is asking how is the patients, wants to use the MYOBRACE. They are committed, they are less committed.
Yeah, you get all kinds. It's the same thing we have to go through when we teach children how to read. You can hand a book to a child. They may want to read it, they may not want to read it, but they're all going to have to learn how to read. Yes. Or at least up until this point in humanity they have.
Your patients are cooperative?
No, they're not. The only place that children are completely cooperative is in China. And I know that because I'd lectured there, and at one of my lectures, 10 orthodontists showed cases, and every one of them was better than anything I could ever do. I was amazed at what they're achieving with the MYOBRACE in China. And I said to them, tell me, please, how do you do this? I mean, I was supposed to be the big shot expert. And yet the results they got were amazing. And they looked at me and they smiled. They go, Chinese children do what they're told.
My child is also putting in the Myoza.
Oh, good.
And he's doing what my mother is telling him. And
good.
It's good results till now.
Ah, beautiful. Yeah, and some kids, they may not understand why they're doing it. Kids don't always know what's good for them. But parents have to,
to be there, yes.
Yeah, they have to be there. They have to make sure that the kids do it, just like they brush their teeth and change their underwear.
And they go to wash themselves.
And wash themselves and, eat real food. It's what you have to do to raise a child.
Yes.
But it is true that in our culture, braces have become such the standard that it's almost, kids think it's, they'll be more popular if they have braces. It's a status symbol.
Yes.
But it won't be long if I'm thinking right, it won't be long before people will understand that they want to be healthy, not just good looking. And then the culture will change a little bit around that. We'll still need braces, you know, to make everything perfect, if perfect is something you want.
Yes.
But health is really
Much important, much more important.
Yeah. So that's good.
Any questions? Anyone else?
So anyway, I said to Moshe that, you know, I'll stay probably at least a week and maybe two. If my wife wants to come with me, we had such a wonderful time. God willing, you know, and Ayal and Hadass, they were such good hosts. Met so many wonderful people. It was just great. So I can't wait to come back. But I also want to help in any way I can. So
so I'll talk to him about the 6th and 7th, and we'll write you an email.
Yeah.
Thank you very much.
You're welcome.
Bye.
Talk to you soon.
Bye.